Good morning. This is Dr. Amjad Obeid. Welcome from ICEM Hamburg 2026. We're starting our first session today with our great colleague, Dr. Soon-Joo Wang, who's going to talk about geriatric ED models and applications. Dr. Son, the floor is yours. You can just enlighten us about geriatric emergency department models and applications. Thank you.
Thank you, Chairman. For me, it's the first time to social media stage. Everybody will the first time. And originally, my presentation was fourth, but the order changed. My talks, I like this. First, geriatric emergency care shortly, and most important thing is the geriatric ED model, and then in geriatric ED environments, and how about the samples of worldwide? Maybe as you know, for geriatric emergency care quality, ICEM made JEDA, Geriatric Emergency Department accreditation program. It is divided 3 levels. So emergency departments are now adding protocols and features vital to elderly care. Like this, everyone is interested in the geriatric care. For geriatric emergency care, the ICEM JEDA subjects were divided 7 fields. For example, staffing is included like this. It can be complex, but based on this guideline, the JEDA could classify 3 levels. So, ordinary adult emergency department care is different from geriatric emergency department care. So, if a patient comes, triage and history physical exam or the lab and X-ray, but in geriatric emergency department, this and the right side subject will be added. For example, seen by JED team. Physiotherapy, social work, nutrition, nursing, pharmacy, and screening procedure, and discharge planning, transition of care home assessment. It is complex. So, how about the geriatric emergency department model? There's a method classified 2 types and 4 types. The simple 2 type will be classified regional community model and specialty integrated care model. Regional community model, you see the general emergency center plus geriatric emergency care. But specialty integrated care model is the objective major geriatric complex disease. So it is focused on the course and result. But community model is the evaluation factor is resource and operation. So as you see, the approach method, the regional community model is horizontal, but specialty integrated care model is vertical. So regional community model is applied for to regional emergency medical center or higher center, but specialty integrated care model it can be applied geriatric specialized emergency medical center. How about the 4 classification model? I recommend this 4 classification model. The number 1 is the geriatric ED unit model, 2 is geriatric practitioner model, 3 champion model, 4 is observation unit model. I'll explain one by one. For geriatric emergency department unit model is applicable model for regional emergency department or higher. So the space will be within the general ED. The facility is focused on the elderly patients, and staffing is important for there is a unified team, and they use geriatric-centered approach. How about geriatric practitioner model? This is opposite side from first. It is elderly specified ED model. The space is only for elderly, so other patients, younger patients, is prohibited. Yeah, and facility is similar but focusing on geriatric patient, and staffing is specialized also. How about geriatric champion model? It is specific, especially for cost-saving model for small emergency department. Space, facility, equipment is similar, but staffing, there is a new model for geriatric champion. So-called geriatric champions leads geriatric care pathway. For example, staff education, protocols, and maintenance. The last one is the geriatric focused observation unit model. It is similar to combination of first and second, but it is not just combination. The space is similar for first one, but there's observation unit less than 1 day. And also the characteristic for staffing is geriatric team shared with inpatient service. Inpatient is important, so like the admission. So this is just a summary. So the baseline factor is space, hardware, staffing, evaluation, and characteristics. If you work in very big emergency center, what kind of model do you choose? You can choose number 1 and number 4. And if you work in very special geriatric emergency department, what kind do you choose? You can choose, I recommend number 2. And if you work in the cost-saving emergency center, I recommend number 3.
So different levels and different categories for them.
Yeah. So I'd like to talk about the geriatric emergency department environment. There's 4 factors for geriatric patient: vision, hearing, environment, facilities. For vision, the lighting is very important, especially lighting the darken at night. So I recommend smart lighting, and every character should be large print, signboard, staff names, even clock, and even telephone characters. And vision aid is also important. How about hearing? Soundproof curtain and hearing device is essential factors. And then environment, structure for natural light is very important, especially for prevent geriatric delirium. It's important. Also for geriatric patients, and temperature control is important. Facilities, pressure reducing mattress and supporting chair rails, anti-slip surface, and other senior friendly equipment you can choose. But as you see, so many facilities and many equipments, you can invest much money. So there's some recommendation, simplified core facility, we call JEDI package. It includes egg crate mattress, hearing aids, magnifiers, rubber mats, and plus cost-effective structural change. So this is a sample of geriatric emergency department in worldwide. This is U.S. Example. You see some holistic lighting and smart light and soundproofing curtains and walls. Flooring is non-specific. This Singapore example, and they have geriatric emergency medicine care space also and staffing. This is example of U.S. Ohio State University Hospital. I'll show you this geriatric equipment. This is example of Mount Sinai Hospital in New York. They recommend the early physiotherapy and occupational therapy involvement because 1/3 of geriatric emergency department visits is resulted in admission. Also, they want to prevent delirium, so they use diurnal lighting. Another example, natural light environment and equipment facility in United States. So this is last one. Yeah.
You're on time. You're on time.
Yeah. Take home message. I'll show you the geriatric emergency department model, 2 kinds and 4 kinds classification. I recommend 4 kinds. and every geriatric emergency department, but every geriatric ED is different. Like no 2 geriatric patients are the same. So geriatric ED should adopt adequate model. I recommend 4 classification. And also operation system based on geriatric ED guideline. Also geriatric ED have elder-friendly facilities and environment based on the medical physiological requirements of elderly. So I want to expand the adequate geriatric ED model. Improvement geriatric emergency medical quality of care will be done. I hope. Yes. Thank you very much.
That's very interesting. Really, I like the talk. Is very, very promising. But you mentioned actually most of in your presentation, that's all about the equipment and facilities. I just want to know about the training.
Yeah.
What kind of a training that you want to have our staff to be more in training? I mean, that is facilities, equipment to be purchased. But how about the human being, the training, of nurses, doctors, paramedics? Any specific training or training sources or courses that you need to you want to train your staff about geriatrics?
Yeah. So,
geriatric care and ED.
Because this time the topic was only for model and operation, but training is a different subject. Yeah. Also, I surveyed international geriatric medical training. So it is very complex. Some countries have combined internal and family medicine geriatric training, but there's no independent geriatric emergency medical training still. But there are some fellowship courses for geriatric emergency medicine.
That's very interesting. Actually, Ali, I think I was expecting is there kind of fellowship programs or courses or masters in geriatric care in emergency medicine. I think it's something that we have to very promising, and we have to always take care of our geriatric patients.
Yeah.
A great talk. Thank you very much. I really appreciate your talk. Thank you, doctor. Thanks a lot. Thank you.
Thank you, Chairman.
Yes, sir. Thank you very much. Now we'll go to our next speaker. We have our gentleman is going to be from South Africa. Is going to talk about surviving in a South African ED, helping most of your patients to survive too. Give me a great pleasure to welcome Dr. Sean-Phillip Fourie. Hi Sean, how are you doing?
Hi there.
All good?
Thanks to you, Chairman. Very well, thanks.
Okay. So you're going to give us a talk about surviving in a South African emergency department, helping most of your patients to surviving too. Floor is yours. You've got 15 minutes to go.
Thank you so much. Hi, my name is Sean-Phillip. I'm from Cape Town, South Africa, and I'm working there as an emergency doctor. I'll give you a rundown of how our sort of medical structure works in South Africa.
Wonderful.
But this talk is generally geared actually towards junior doctors finding themselves in positions of as a team leader, and how I would recommend, in my experience over the last 2 years, optimizing your team, optimizing your units, and then just looking after yourself, and what I've found to help quite a lot. This is a quick look at the healthcare system in South Africa. On the left there you've got at the base of the healthcare system, you've got local clinics. They deal with chronic condition. There we go. Like sort of chronic conditions, primary healthcare. That is what this would be. And then district hospitals or secondary hospitals will generally have specialists on board, and we will refer up to tertiary hospitals, which will have things like neurosurgical departments, catheterization labs, and whatnot. And then here on the right, we've just got a quick look of what the medical hierarchy in South Africa looks like. So after graduating medical school, you'll be intern, where you will do at least 3 months in most major rotations. And after 2 years, you'll graduate to the level of community service doctor. Thereafter, you're called a medical officer in South Africa, and this is where a lot of my colleagues find themselves in positions of leadership. And you'll notice that above that is actually a registrar. So this is, in my country, somebody who's a training specialist, leading up to the top of the ladder, which is a consultant or a specialist physician. So a lot of people here in this middle tier find themselves in positions of leadership, and it's burdensome on your mind. And what I've found over the last 2 years in my position is that you need to look after quite a few things to make sure that you are going to be productive in your shift. So this is the hospital that I work at. This is Mitchell's Plain District Hospital in the Cape Flats in South Africa. It's a very impoverished community. There is a lot of trauma, but that is actually not the majority of what we see in the emergency department. We see all undifferentiated patients, medicine to trauma to obs and gynae, peds, you name it. And on average, I would say we see about 150 patients per day. Staffing looks like 4 to 6 doctors on shift at a time of varying levels of seniority, and then during the day we've got consultants, so specialists on the floor. After hours, however, they are on call from home.
So you have you don't have a consultant 24/7, it's just during the morning or evening
However,
shift.
they are always available telephonically for any advice that might be needed, and if things really go pear-shaped, they can come in if needed, but they're generally not there. And it looks really beautiful on the outside, and unfortunately that's not the reality on what's going inside.
And this is how emergency departments are. That's what we have.
This is common in any resource-limited setting with high trauma burden.
It is,
and
of course.
As a young doctor coming into like a team leader role, this is really it's quite taxing on just your psyche to begin your shift like this. So I think that loads of my colleagues will know that film on the left, that's a resuscitation going on as you're trying to do your handover. And on the right there, we've got like a picture of our majors area, loads of patients who unfortunately are on the floor. We're under-resourced. We don't have stretchers for all these patients. And there's a lot of moral injury that comes with this, and we'll get to how you need to look out for yourself. So what do I recommend? I recommend taking a breath. And then, I don't know if I just come from a long line of alcoholics or I just like the serenity prayer because it tells me that I need to accept things that I cannot change. But this is something that I think needs to be etched into all EM practitioners' brains. Do what you can and know where you have to, where you can't add any value.
Do your best. That's it. Just try your best.
So the three things or the three prongs that I think that we can act on would be your unit and your patients, your team, and yourself. So talking specifically about your unit and your patients, this is the system that we use to see who's next to be seen, and you can see it's a sea of patients. The ones without any color code next to them are the untriaged. And when you're starting your shift, I think that it's important to really do a mindful and intentional walkthrough of your unit, know the unit, and know who are the sickest people. The untriaged are the sickest until proven otherwise, and you need to really at this point get to grips with which patients are posing diagnostic dilemmas. Involve your consultants early, you're not alone, and really...
So, do you use any specific triaging system that any specific ones, the Canadian
we're paper charting.
Yeah, any triaging system, any specific ones you use for the triaging?
We're on we have a one that was developed in our unit, and it's all paper based, and everything gets loaded onto an electronic system later. Yeah, find the sick patients, prioritize them. Find bottlenecks and delays early on so that you can involve the necessary role players early on. You know, this doesn't all have to be on you. You need to involve the matron for issues that are pertaining to them. Bed manager needs to know if there's a big bottleneck. You need to involve everybody. And situational awareness is paramount. You need to be on your toes. You need to go into your shift with open eyes. And I think that's something that as emergency medicine practitioners in general are all guilty of, is that we are always scared to make eye contact with the waiting room, with the patients waiting to be seen.
Of course.
And there's a level of shame that comes with it. I feel shame when I know that a patient is waiting really long to be seen, and I don't want to look up, I don't want to. But the problem is that the patients that are loud and in your face are not the ones that are dying before being seen.
So you look at them just to triage them, actually, a visual triage, just to pick up if there's anyone sick there in the waiting room.
Next, when you get to actually seeing a patient, I'm going to encourage you to connect, collaborate, and be compassionate, because there's a really good podcast with Scott Weingart and Stephen Tosiak that they outline what he found in his book, what he describes in his book, Compassionomics, and essentially making that extra minute of care compassionate and caring towards the patient.
This is the word, compassionate care. This is the word.
Yeah, and you just need to, that enhances the patient's experience, but also the clinician's experience.
Of course.
And finally, reduce cognitive burden wherever you can. You need to find where you can make a protocol and make it.
Definitely.
And that is something that I'm so grateful for in the unit that I work in. And this is just three of the really common, the most high yield protocols that we use. The one on the left there is for starting N-acetylcysteine. We see a lot of overdoses. Then the middle one is for traumatic rhabdomyolysis, crush syndrome. And then finally DKA, we manage DKAs until they're out of DKA. So these are three really high yield ones that just decrease cognitive burden on the clinician so much and are so helpful, and that is really protecting you. But I must say that I think probably the best thing that was developed by people in my department is that little sticker on the top. And that's a sticker that goes onto every ECG that happens in our department. And it asks a binary question.
So what's the story of the sticker then?
The sticker asks, is there a STEMI or a life-threatening dysrhythmia?
Wow, okay.
Because on a shift, how many ECGs get popped in front of you?
As your vital signs. I think consider your seventh vital sign.
Is the patient having chest pain? I don't know. So this asks, is there a STEMI or a life-threatening dysrhythmia? If yes, stop what you're doing, take the patient to resus. The patient needs immediate care. If no, cool, the patient can get a TROP, the patient can get another ECG. We don't have to stop what we're doing right now for this patient. They can get adjuncts, they can get other things, but you don't have to stop what you're doing right now. And I think that this helps so much. The next prong is your team. These are some really good teams in South Africa. That's our 400 meter relay team who won silver last year at the Olympics. That's our female, the Proteas female cricket team, and then those are our boys in green and gold. They are our national treasures. And then arguably the next best team in South Africa, Team 3 at Mitchell's Plain.
Wonderful. The amazing team, the dream team, isn't it?
And something that's cool about where I work is that we work on fixed teams. So I know this isn't possible in a lot of places, but I would encourage that if you're ever in a position where you can allocate teams, that making a fixed team for 3 months at minimum is really, really beneficial for these first three things that I want to say, which is basically all talking about creating a good culture and knowing your team. you need to know the names of your teammates. You need to know what their strengths are, and most importantly, you need to know what their weaknesses are.
Definitely.
You need to know that this person who's working with you is not confident on an airway. That's a person to flag for the next low-risk intubation in your unit, not the person that you want to be tubing or being put on airway during a resus scenario. You know, that's really important for you as a team leader to stratify early on. Breaks are mandatory, and preferably they're together. See, I left out a word. Preferably together. So when your unit allows break together, make a point of it, because it really is important.
That would be a bit difficult and challenging to go together for a break, but anyway,
you say that until you do it.
It would be really, really difficult. Just
if you
guys, we're just gonna go for a break for half an hour. No patients in.
You'd be surprised. You can. Patients behave.
Okay.
And it's incredible for the team culture, which also helps so much with what you are able to achieve as a team long term.
Good.
Also, I understand it's not always possible.
Of course.
But when possible, make it happen. Empower, encourage, and acknowledge. This photo only has doctors and students in it, but your whole team starts at the front door. I mean, the porters, the security guards, the admin clerks, everybody's part of your team, and it's important to acknowledge when everybody's doing a good job. And you need to foster a place where open communication is really empowered. You need people to be able to tell you that they're not doing well or they're doing great, and you must tell them when they're doing a good job. And finally, debriefing. I think that this is people forget, but it's really important. You need to, what we do in our unit after an unsuccessful resuscitation is always to take 30 seconds for the life last, and that's a beautiful time also for you to breathe. You've just been through something really traumatic.
Definitely.
And then thereafter
it's extremely important for you, for the team, just to keep on going.
So finally, the last prong is yourself, and I suppose that this is probably one of the most important ones. And as an EM practitioner, you are expected to know a lot, and you should know a lot. You're dealing with high risk, high reward scenarios, and what's even more important than knowing a lot is knowing what you don't know. Absolutely. And this is something that you always need to be comfortable with, because it's uncomfortable. It's not nice to accept what you don't know. It's not nice to, it takes a lot of bravery and a lot of humility, and you need to know when you need to ask for help.
Sure.
So even though at night we feel, after hours, you feel really overwhelmed, there is always a consultant that is on the other side of a phone. You can get some input. You just need to bounce some ideas. And this is also really important for the people that are looking up to you. You need to show them and empower them to identify when they're out of their depth and know that it's okay to ask for help.
Yes.
Tech is your friend. We live in 2026, and you don't get left behind. The phone that you have in your pocket all the time is a plethora of knowledge.
It's not for your social media, it's for even you can get also some lots of help as well. You can get a lot of, like, I mean, things like UpToDate. Please, UpToDate, if you're listening to this, make it less expensive. But you know, like, evidence-based medicine is at your fingertips all of the time, and you don't want to get left behind. I want to talk about adaptation and innovation, which I think is something really important in emergency medicine, and this is one of the reasons why I love this profession, is because we have to be adaptive, we have to innovate. If the bed that you're using for the patient that you're thrombolizing doesn't go into reverse Trendelenburg when they are hypotensive, get something and put it under their legs to help them out for the next 10 minutes. That's a bin that we've just emptied out. Or, you know, we don't have Thomas splints for mid-shaft femur fractures, and this is something that was developed in South Africa that uses a crutch and a traction set, and that can give you good length on a femur fracture. That's my boss, one of my mentors, and really like an icon, I must say, Katja Evans, and she's doing what we call a fluorocotomy. So that's when you're doing the thoracotomy on the floor. And just be inspired. So these are my bosses. These are the people that I get to look up to every day. This is not what they wear every day. They're all female, right?
Mostly female, which is awesome. Martin de Man is the middle one. He's bringing up for the men. And finally, look after yourself. Mental health. Mental health.
Definitely, yes. I cannot disagree more with you. I mean, it's an absolutely surprising. In medicine is just the same. We speak the same of the common language all over the world. Whether South Africa and Middle East and Europe and States, we speak all the same, and all the challenges are the same thing which we have it. So interesting talk, and I love it actually. Keep doing whatever you're doing, guys. Keep the innovation issues. Work as a team. I love the teamwork concept, doing as a Shafiq, I think it's a beautiful one. Amazing. Thank you very much. Very interesting talk. Thank you, sir. Thank you very much. Thank you for being on time as well. Thank you. Thank you. Thank you very much. Thank you. Thanks a lot. Thank you. Okay, we're actually on time. So invite our great next speaker. Have a seat. Hi, sir. How are you doing?
Thank you.
Oh, good.
I'm doing fine, and thank you for having me here.
You're most welcome. So our very special guest, he's from Malaysia, and he is gonna talk about social media challenges and opportunities. So just would like to welcome Dr. Idrose Alzamani from Malaysia.
Yes.
Okay, and he's gonna give us a very interesting talk. We all have social media at the tip of our fingers,
Yes.
but we need to make use how effective and how useful it is for us. So, floor is yours.
Thank you very much. I'm very excited to be here, and I will be sharing my perspective on the social media in terms of the challenges and the opportunities based on real life experiences. Because through social media, we experience lots of crises, and I will share exactly what we did to overcome those so-called perception disaster. Before I proceed, I really like to share with everyone that next year the ICEM 2027 will be in Kuala Lumpur, and for the first time there's a rebranding exercise by IFEM itself, calling it IFEM instead of ICEM. Please come to Kuala Lumpur, and I will be sharing my perspective based on Kuala Lumpur. And this is the
date as this year, right? June. Is this the same date as this date?
10 to 13th June next year. Right. So for a start, I just want to share with you how powerful social media is. Because as you can see, the world has 8.3 billion people on the planet. And out of that, 5.07 billions are on social media.
Wow.
And if you could, it's kind of a different world altogether, or different religion in a way, because what you influence to that 5 billion people means that you are influencing 60% of the world population. So this is the thing. It is an unofficial means of communication, but most powerful, highly influential, and it could cause perception crisis that could affect you, your system, your organization, and we could be a subject of ridicule, cyberbully, low self-esteem, and you could even be depressed by it, and wrong or unfair information, and even cause unrest among the public. And people with the highest number of followers will have the high power of influence. So for a start, do you know that Cristiano Ronaldo has the highest number of followers in the world, and that is about 1.2 billion followers. And what he says, what he wears, would affect or influence people. And for that alone, he gets a lot of money. Now, let me bring you to earth, to who I am. This is me. I'm on Facebook. Wow. And I don't have 1.2 billion people to follow me, but I got 96,000 followers.
Wow, so influencer then.
And in a month,
influencer.
Well, in a month I get about 2.3 million views of what I put on social media.
Amazing.
These are the thing. All right. Okay, the slide is kind of stopped. Okay, this is the thing about being an influencer. You call someone as a micro-influencer once you have more than 10,000 followers. And once you got more than 100,000 followers, you're a macro-influencer, meaning that you're pretty influential. I'm not there yet. I'm 96,000, but I'm almost influential. But here's the thing, you are actually it's kind of a world of the against the dark forces. Because if you are familiar, when you're on social media, you'll be surrounded by lots of negativity. And for this, I'm sharing you my real life experiences, how it affected my hospital, my department, my staff, and how I use my power, sort of, my little power to overcome those challenges. This is one of the example. Once I was in Japan, I was speaking there, and then I looked at the social media. There's a viral issue of my staff, my hospital, being caught eating a snack in front of the triage counter. And the caption went like, this is what emergency department staff do. They eat, they play with their phone. And you could imagine the whole country, people becoming armed with their phone and using that to threaten our staff. And it's a scary situation. And I went back, I studied. And if you look at the counter there, there was no one at the counter needing a service there. And it was at this point when I look at the CCTV, this is what I found. There was a lady who came at the side of the triage counter, and just at the point when the snack touched the tongue, that the photo was snapped, and that was captured in that, this is what ED staff does. They eat, they play with the phone. So I put that up. I put this CCTV photo, and then it became viral, and it out-viral the earlier viral version of the crisis. In fact, the earlier version was captured on lots of mainstream media. And once this was seen and became viral, this too was captured on mainstream media because I put some threads in there, including what the law says about, snack, taking pictures in the public hospital. So that kind of killed that perception. And on top of that, I also put on my account our CCTV monitoring system. And when they saw this, they kind of know if they come and do some funny stuff in front of my counter, they will be captured. They are being watched. And this too was got onto the mainstream media and reported. So that's a case number one. There's another case for which a nurse was caught because in this district hospital, there was no ventilator. So this nurse was begging the patient and was looking at the phone. And then someone said, how could a nurse do that? You're looking at the phone while begging. If you have an experience of begging for 8 hours, you will know how hard that is. And this is the reality when the ventilators ran out. So it became viral. And then I decided I need to protect this staff nurse.
So they were appreciating her work?
No, they were condemning her because she was looking at the phone.
But she was begging for 8 hours,
She was the begging. The video showed it was begging at the right rate. So I commented, I said, he was begging at the right rate. Never his hand stopped begging despite looking at the phone. And he might be asking his husband on the phone whether the husband has come home, whether the child has eaten. Of course, I played some drama and emotions in it.
And she cannot move from for 8
yes.
hours. She can't even go.
Yes.
She can't even go to the restroom, or drink, or eat anything at that time.
True. And then that became viral, and
Wow.
it kind of like doused the fire created by the first perception. So this is how we try to protect our staff in reality. Another case, my hospital was on fire. And at that time, as you know, the world of the social media, they would have conspiracy theories. The fire location was close to our forensic department, for which there were files of high-profile files.
Oh, yeah.
And there was a conspiracy as if we're trying to delete all the evidences. On that day, I was not working, but because my hospital was on fire, I went to the hospital. And before that, we had always had these drills when the hospital is on fire. And actually the system went well. They went to the assembly area and it was handled pretty well. I got a call by a special officer of the Director General of Health. So this was the situation at that time. It was quite all right, handled at the assembly area.
Well organized, looks very organized.
Yeah.
No chaos.
Yeah.
Okay.
And my Director General said, can you write in your Facebook in a manner of the glass is half full? I kind of get the drift, meaning that to make the people see positively. And I did. I wrote. I said, thank you for all the concerns. I said that the system followed exactly like what we practice. Nobody died, and we thank all the fire and rescue services for coming and stopping the fire. The matter is being investigated, and we appreciate all the support from nearby hospitals who were asking and showing concern.
So lives were preserved. No life was
yeah.
lost, right?
No life was lost. And the it changed the public perception from a condemnation of trying to hide evidences to sympathy and empathy, and everyone saying, well done, hope everything gets all right again.
And just flip them.
Yes, it's flipped them. So it's kind of the fire that was started is being doused by by a fire extinguisher, a social media speaking.
Wow.
So this is what it looked like. That was the exact account. We got like 2,500 likes and 895 shares. When we translate that into views, that would be easily 100 to 200,000 views, changing the perception with something that doesn't cost anything.
Of course.
Okay, I would like to bring you back to during the COVID-19 pandemic.
Yes.
That was a very challenging time. Remember, with all the anti-vaxxers, with all the conspiracy theories, it was a very tough time. And during the COVID-19, I was coming into my shift, and then suddenly, when I arrived, they said, have you heard? There's a train crash. We got about 50 patients. And then suddenly my phone came from all over the world asking, how are you? Are you all right? And apparently they found out there was a train crash near my hospital, and then underground. And this was what went on the social media. It was already all over the world of the real incident of the train crash, of the victims, and what's happening. So I started the shift. Actually, there were two trains that had a head-on collision underground, under the Twin Tower.
Wow.
This was what happened on that day.
Okay.
So we were already having COVID-19 pandemic, and on top of that, a mass casualty incident. So we handled it. In fact, we followed our disaster plan. We have the red, yellow, green areas for which it was modified at the incident site according to the level of the underground.
Okay.
And we handled it, evacuate people according to the triage protocol. And
so that's pre-hospital care.
Yes.
Before they arrived at the
yes.
hospital. Okay.
And then at my hospital, 12 ambulances suddenly appear, but we activated our disaster plan. And at that time, we had to check the temperature and all. Remember those times?
Yeah.
And made everybody wear masks. And it followed the plan pretty well. As we expanded our capacity, we were able to handle about 62 patients.
Okay.
And 6 of them very critically injured.
Wow.
So by about 1 a.m., I entered my shift at 10 p.m. In a matter of 3 hours, we were able to handle everything. All patients sorted.
Well done.
Yeah.
Well done.
And then we arranged for the surgery and everything, and we were able to stand down by about 1:30.
Oh, wow.
By 1:30.
That's an achievement, actually.
Yeah. Once we stood down, we continued with handling the COVID patients and all that. So I'm just saying that at the end of the shift the next day, I thought, I made a report of what happened, but I thought that why don't I just write something on my social media account? And before I went back to home, I did, and I just put it in. And as I arrived at home, when I look at my handphone, it became viral.
Wow.
The Director General shared my post just about 5 minutes. I put it in.
Wow.
And we got like something like 250,000 likes.
Wow.
For
How far
this.
is your home from work? How far is it?
About 20 minutes away.
That was quick.
And what I saw at that time when I wrote it, it was to showcase to the whole country that emergency department, we work as a team. And we show to the people, even during the crisis, during the pandemic COVID-19, and when there's even a disaster, we are there for people. And for that, it helped to unite people, to say that don't be anti-vaxxers, don't look at us negatively, and trust us. And for that day, we believe we had created unity. We have united the whole country to believe in the healthcare system.
Wow.
And actually, I published this paper in the journal of how we handled it during the COVID-19.
Well done.
But
Well done.
I got to tell you, when you publish in the journal, it is void of emotions, of your anxieties, of what you're afraid, your scares. But when you capture it on social media, you could incorporate all that, and that's real. So these are the opportunities for us to give the perspective of the issue, to educate our staff, to create awareness with zero cost. And I've been using it, for example, to showcase for people to appreciate. For example, in Malaysia, you get emergency care for RM1, which equates to about 30 cents US dollars, and you get everything, ultrasound, CT scan, for people to appreciate. Because we got a lot of criticism. I use it as an education tool. For example, this was...
this is very important. Yes.
Yeah. I could, as I teach my grand rounds, I could have like 50 people that I teach. But when I put on the social media, like this view, I got on this pediatric asthma, for example, this was quite recent, I got 38,000 views just like that.
Yes.
That I'm educating 38,000 people. And that's, to me, is powerful at zero cost. And I'm trying to build a connectedness for people to believe, to come together. For example, when you resuscitate one patient, regardless of the race, religion, or color, everyone with various race, religion, or color will come together to make sure that he lives.
Of course.
So that's a beautiful philosophy for us to live in emergency medicine. And
that's what we do. Well, that's who we are.
Yes.
We do that.
So we put it on the social media. That become a powerful tool to unite everyone and to come together for humanity. In trying to make my people healthier, because our department is congested, I walk 10,000 steps every single day and showed it on video on my social media account, so that they will follow what I do, and hopefully they will become healthier, and 5 years, 10 years down the road, they don't have to come to my department and congest my department. And because of this, there was a group that was inspired. They formed a group, and right now that group has grown to 200,000 followers who keep doing this, the brisk walk of every single day.
Wow. Wow.
And this is actually the 15 reasons why I write on Facebook.
Amazing. I love them. I want to hear them. Yes, tell me. Just go.
To spread positive values, to educate the public about health, to share knowledge, to encourage people to have a healthy lifestyle so that they stay healthy and do not need us, to make you laugh once in a while. I believe humor is important, to promote family values, to build an ethnic bridge among diversity of communities as a self-reflection, as a record of my professional activities for reference in my diary, to build healthy relationships in the community through noble values, to give the public a better understanding of the emotions and feelings of healthcare practitioners, because we are humans after all, to build understanding about the organization and health system where I work, to highlight rationally in thinking for the public, to invite all nations to be patriotic and love the country, to balance the positivity against the negativity in the world of social media. And for this, I'm achieving 2.3 million views
on
average
good for
every
you.
month.
Congratulations.
I wish everyone would pay $1. I will be a millionaire overnight.
Wow. A cent is okay.
Yeah, but at least in values. It's in values. So it is a battle to win a war on perception on social media. And we do not provide our perspective. We are shaped by what others tell about us. They will define us, but we could use it back to define who we really are in reality. So in conclusion, we cannot ignore the power of social media. It's a tool to manage perception. And there's lots of opportunities to use it to our advantage, to educate people, staff, with zero cost of advertisement, to influence others on humanity and good values. And we need an ally of goodwill and positive values. And we do not, if we do not provide the perspective, we are going to be shaped by others about us. I hope to see all of you in Malaysia next year.
Of course.
And maybe just for 30 seconds, watch this on the screen. That will be one in diversity and rise for humanity, and for which I invite all of you to come. Join us as the next ICEM. For us to share experiences just like today, and that's what
emergency medicine brings us together in the most critical moment of humanity. In those moments, beyond borders and background, we are united
and that's
by
what
one
Malaysia
purpose,
looks like,
to save lives
what it looks like,
and to serve with compassion.
why we say
at IFEM 2027 in Kuala Lumpur, we invite the global emergency medicine community to come together to share knowledge, exchange experiences, and inspire one another. Here in Malaysia, our diversity.
So for this, come join us. You can submit your abstracts already, and the registration is open now.
Wow.
And thank you.
Well done. It's an amazing talk. We've got lots of audience. I mean, I'm really, it's a beautiful talk. But Dr. Zamani, why in social media? Why we are reactive? We are not proactive. I mean, with the incident which you just shared with us, that they saw, oh, that doctors is having a bite, keeping the patients waiting. Why you are always reactive, not proactive? It's a media. It has got we call it a sword with two edges. Something can be beneficial. I just said exactly all the 15 points we just mentioned, how we can influence and spread the positive thinking about healthcare and about emergency medicine. But we are always, whenever we have something on social media, we have to respond. No, it was not this way. We have to defend ourselves. And this is actually what's happening. We are very much we don't want to go to social media to post about our work, about personal work, because we feel that, we are violating any kind of, we're worried about from being blamed for having sharing things on social media about your work, about your patients and all of that. But unfortunately, we are becoming reactive rather than proactive.
I think it's about storytelling. If you notice, the most powerful thing in the world is stories.
Exactly.
Why people gossip, why people get lots of attention from stories, why religion gets spread through stories.
Definitely.
So what we're doing we're witnessing unfolding in front of our eyes is the storytelling of the world, and the stories that get told the most will define the social order, the norms of the world. And if the majority are sharing the negativity, the world will be defined by that. So we've got 8 billion people, and if the majority of us would understand our responsibility in sharing the positivity, in sharing the good stories, in shaping the narrative, so that we view the world as a tool for us to come together and to grow higher and to be powerful as a force of positiveness.
And definitely, and actually to oppose the negativity against the healthcare by itself services. Now patients are they've got access to social media. Anyone who's got no background, no knowledge, no scientific background, it says, okay, don't eat those food, don't do that, and they spread a negative or even a wrong information.
Yes.
And we're just the patients come to us overwhelmed. They say, no, this is not good for health. I'm not going to do this. I hear that if we do CT scan, it's going to injure my kidney. I'm going to do this. So they are coming with a wrong perception. Okay, they are aware, but they were not given the right information. It's our rule that we have to really rectify that, especially in emergency medicine. We've got lots of wrong concepts and lots of wrong rumors from non-medical influencers, unfortunately, on social media. And they say, this is not good for health. Don't eat this, don't do that. And then they've got nothing to do with medicine at all. We cannot stop actually discussing with you. It's such a beautiful talk.
Thank you very much.
Endless discussion.
Thank you very much. I'm very happy.
We'll finish our talk maybe
here
in Malaysia next year then.
Yes. Come to Malaysia, everyone.
I really appreciate it. Thank you, Dr.
Thank you very much.
I appreciate it. Thank you. It great pleasure to invite our next speaker. Okay, Dr. Roemer Tanghal. He's going to talk about opening the emergency door, integrating palliative care in the ED of a tertiary LMIC hospital. Dr. Roemer, how are you, sir? Doing? Good morning. You've got 15 minutes to go.
Okay, Guten Morgen. Good morning.
Guten Morgen, yes, good morning.
Yeah, so I'm Roemer Tanghal. I'm a palliative emergency physician from the Philippines, and thank you for giving us this opportunity to share our story from the Philippines.
Pleasure and honor.
Yeah. This story is about an emergency department which is overcrowded but became a haven for palliative care. So let me just move.
Very interesting.
Yeah. I have no any conflict of interest to disclose. So I just want to give you a background of our country, the Philippines. So the Philippines is found in Southeast Asia. We have about 7,000 islands.
Wow.
And we have a population of about 118, nearly about 118 million Filipinos. Our form of healthcare system in the Philippines is a mixed type of both private and public sectors. And just to let you know, this is where I am working. So I'm caring for my emergency and my palliative patients in Philippine General Hospital.
Looks beautiful.
It's a tertiary.
Very green, very beautiful.
Yes, we are operated by the University of the Philippines,
Wow.
and it's a tertiary and referral center with about 2,200 bed capacity, with serving about 600,000 patients per year. But just to give you an idea, in our institution, specifically in our cancer center, 55% of our patients were actually stage 4 cancer patients. And this actually gives us some sort of a parallel trend globally, that there is actually an increased number of patients dying, and this is caused by what we call NCDs, or non-communicable diseases.
Yes.
And even as early as 2021, WHO already released a statement that there's a huge shortage for palliative care services. In our country, our top 3 causes of death is still ischemic heart disease, neoplasms, and cerebrovascular diseases, which are all actually way screenable early, preventable diseases. But still, this gives such a lot of agony, especially to those from the low and low middle income countries.
Yes.
Even though we have a very, very huge population of patients who are in these conditions, based on studies, only 14% of patients who need palliative care services actually receives it.
Wow.
Only 14% globally. This is a global figure. With it, I think we are trying to move forward from there. We wanted to make sure that the ED, even though we have all these challenges, can be an access point. These are the more common challenges in a low middle income country. Sorry. First, I think this is global problem. We have overcrowding and limited resource problem. Second, we have very, very few palliative care specialists in the country, and if there is such, they're actually stationed, or they are practicing in urban areas. There's limited training, and of course, there's always cultural barriers to end-of-life discussions.
Yeah, but palliative care specialists are palliative care medicine, but not emergency medicine. Do you have a palliative care emergency medicine?
All right. In
your talk.
I think I took that initially. I termed this as a risk. I told my colleagues that I'm trying to pursue on palliative care while there's even no EM palliative care yet in the Philippines.
Yeah.
But I took this trailblazing task to advocate for palliative care in the Philippines.
Okay.
So we did it. I did some training and went back to my country and served back. And this is my project that I'm going to
Excellent.
share with you in a bit.
We're just waiting for you. Just tell us. Enlighten us.
So this is our vision.
Okay.
This is our vision. Our vision, the ED remains to be the safety net of every patient. It's 24/7 operating. That's why what we can actually address is open the emergency department for all these needs for palliative care. So what we did is we actually train our emergency physicians to recognize palliative care needs. These are most of the things that they addresses. They manage symptoms, they provide end-of-life care, and they conduct serious illness conversations in the ED. And how did we did it? Let me share with you how we started it by creating a vertical horizontal integration model. Okay. So vertically, and horizontal, because in all forms or in all acuity, we should be able to manage them.
Okay.
Our first-year residents receives the foundational concepts. Our second year starts on communication skills and symptom management. They treat patients, those in pain, they treat nausea, vomiting, they treat unrelenting symptoms. And our third year and fourth year goes on advanced care planning, their leadership, they're the one teaching, and soon they'll be the next generation who's going to teach so that we can multiply a lot of a lot of EM who can now practice palliative care. They don't have to become specialists, but at least they have already this basic palliative care in their practice.
Okay.
So one of the most difficult thing that when we were creating the curriculum was actually when we immersed our learners. Talking about palliative care is actually highly emotional. You talk about suffering, you talk about dying, you talk about uncertainty. I have no other resident who wishes to talk about it. That's why we created a program wherein they learn from it while we are actually maintaining a good psychological safety for them.
Yeah. That's
First thing, we did a lot of simulation. So we did a Breaking Bad News simulation wherein our residents are immersed in high fidelity simulation. We are using a framework using the Spikes protocol to actually break the bad news to our family or to our patients. And eventually, this forms creates actually three things. Number one, it prepares the physician for a high-stakes situation. Second, it builds confidence in them. Third, if not the most important, simulation actually gives much empathy, the sense of empathy from our learners. Here is one example of our simulation. It's in Filipino, but just I wanted to show a 40-second clip on how we're actually running it. Okay. So here are 4 cameras in our simulation laboratory. There are actually families around the patient, and they're like good actors, and they're immersed that the patient actually arrested on the spot while the physician and the family were there. And just imagine how difficult it is to actually divulge to a family that they are actually seeing it on the spot. This is common. This is a common setup in our country.
The simulation case that the patient is DNR. And right?
Unfortunately, this patient is not on a DNR. And they have to actually pivot or shift the gear from an aggressive resuscitation to a more palliative resuscitation.
Okay.
Or, sorry, not palliative, but a more aggressive palliative approach.
Okay.
All right. But always, just after any simulation, we always conduct the most important thing, and it's always debriefing. Because again, this will allow the emotional processing. It takes time for them to have this reflective learning, right? And of course, it will build an emotional resilience among the residents.
Amazing.
The next thing is that we actually created a clinical rotation in our own palliative ward. Our residents are able to see patients on an inpatient referral or in the ED. They do rounding, and we actually put some patients in our clinical decision unit.
So they are emergency doctors doing a training program in emergency medicine, and then you give them kind of an extra thing to do than palliative, right? Isn't it like a rotation or an extra month or a month or a few weeks, just a rotation in palliative care? So they come back and then work medicine plus palliative care.
Correct, yes.
Okay,
cool. The main reason is that this is one of the good areas where our residents are actually enjoy. It's called our home visit. It's like ED at home, but they're rotating this rotations under their palliative rotation. They actually try to visit their patients. The good thing in visiting your patients, you actually identify the social determinants of health. You know what is available in the community. You try to bridge what are the needs of your patient. You can actually plan for a good discharge because you already know what's happening in the community for these patients. And lastly, the most a huge impact is actually it avoids this unwarranted return to the ED because the access already in the community. All right. Oops. Okay. We also created the basic palliative care course because, as I've mentioned, you don't need to be a specialist to render palliative care. So we offered a course with the content of pain management, opioid stewardship, management of unrelenting symptoms like dyspneic crisis, delirium, nausea, with some communication and ethical component to both our physicians and our nursing services. Right? And lastly, we also created our own tool already. If an emergency physician do have an ABCDE, we also have an ABCDE just so we can identify those patients in palliative care. A, always ask first for an advance directive. always see the selection just before you put the tube in.
Okay.
Please make sure to check for this ACD. B, always check for better symptom control. We need to make sure that our patients are actually comfortable and pain-free.
Okay.
C, involve the caregivers.
Definitely.
Take note, caregivers do have burnouts at most, but the most important is that we involve them because they
Part of
know
the
more.
decision as well.
Yes, correct. And lastly, that's a good thing. Letter D is for decision-making
I must have
capacity.
thought before, believe me.
Yeah. So it's very, very easy now that aside from your ABCDE, your airway, breathing, circulation, disability, I'm teaching you that there's a ABCDE now for a
Advanced
rapid
directive.
palliative care assessment tool in the ED.
Oh,
in the
wow.
ED.
Wow.
All right. We also have this. This is very much available. It's called P-Care. So it's also a tool if ever you wanted to use this for to identify an unmet palliative care needs.
Okay.
So it's a very, very quick screening. In less than a minute, you can finish this. And just to let you know, this is the impact of all this work that we've done for about 2 years. We've noted from 2023 to 2025, we had an increased number of our delivery of end-of-life care in the ED.
Oh.
We have increased palliative care referrals already. We have rate of hospice and palliative admissions. It means the beds are now being utilized instead of occupying, these beds
Definitely.
for chronic. Yes, we are moving them more to hospice beds. And lastly, we also have increased rate of palliative discharges. Patients who does not need to be admitted are now sent home and they are taken care at home. So I think these are the few lessons that we learned from this story. First, collaboration is the foundation of success.
Definitely.
There's no other way but emergency physician and palliative care should work together. We only have one goal, and that is to improve the quality of life of our patients. Second, palliative care is a skill that can be taught and learned,
Yes.
especially in EM physicians.
Physicians can function anywhere, anyhow. We do all the best.
Yes.
Emergency doctors.
Yes, I agree.
Okay.
And learning palliative care can be emotionally challenging, but we can mitigate this. We have a lot of educational tools to make sure that the emotional burden, we can always give our learners a psychologically safe environment by putting them first into simulation, doing some exercises, a communication exercise between teachers and the learner. We can always have feedback. And lastly, culture change takes time but creates lasting impact.
Amazing. Very nice. Beautiful.
So please allow me to end this session with this quote. We cannot change the outcome, but we can affect the journey of our patients. Thank you very much. Maraming salamat po.
Amazing. Salamat for your nice talk. Salamat. Actually, this is not the end. This is the beginning. I mean, you said this is the end of my talk. It's not. It's going to be the beginning because you are opening a new era of emergency medicine. So, I mean, are we talking about a subspecialty in emergency medicine? Are we talking about subspecialty, a kind of a different people just to go to do a palliative care, especially if you're working in an oncology center? I mean, if you are going to talk about subspecialty, means he does the emergency medicine training program and then he does the palliative care. It's something very promising.
Yes.
And is it available as a subspecialty of emergency medicine?
Yes, all right. I think since 2004, the American College of Emergency Physicians already recommended a subspecialty on palliative medicine.
By emergency physicians?
By emergency physicians, correct.
Oh, yeah.
Yes, by emergency
2004
physicians.
means
2004. Yes, that's why.
22 years? Okay.
Yes,
Wow,
that's
okay,
that was
fine,
already
sorry.
recommended back then.
Okay.
But I think it's not, again, as I have told you when I shared to you the lesson, you don't have to become a specialist to render palliative care. There are different models. One is an emergency physician who subspecialized to palliative care.
Yeah, it's a subspecialty. You can get a fellowship or a master's
Yes.
or whatever, something that now, okay, you are a emergency doctor, you are a full-fledged emergency physician, trained, you've got your training programs, you've got your own, you've done your certification, but you have got an extra awareness of palliative. But the question is that, is it feasible? Is it can we sustainable? Because you're talking about taking those emergency doctors to go home to see their patients. And you showed me another slide with a very busy ED. Can we afford it? Can emergency physician, or do we have that much of availability of emergency doctors to go and do the home visits? Maybe are we overlapping with other specialists, other specialties like family medicine or that's just, what do you think?
Yeah. So there are two more models that I wish to share.
Yes.
The second model is an ED where EM physicians works with palliative care specialists like family physicians, as you have mentioned.
Yeah.
So that can also be feasible. But the third model that I think will be, this is the product of the third model, which is you integrate the training of palliative care within the emergency medicine residency program.
Should be like a rotation a month or so, like maybe can add it to their curriculum maybe?
Yes,
Maybe should
actually ours is just a few hours on each of their year level for their didactics, but the everyday experiential learning gives a lot of the impact. And just to let you know, I just want to say the graduates of my program is over here.
Oh, okay.
Yeah, so they're over here, and they are my first products. So we produce already 2 years of
Should be proud of them. Then.
yes,
Should be
of
proud
our
them.
residents who are already trained to render palliative care.
Amazing. I mean, it's a beautiful talk. Lots of promising things. I think it's gonna be. Maybe we can hear it in the future. Some other people publish about official training,
Yes.
maybe official certification for them. And well, if you want anything to be fixed, just give it to an emergency physician. That's what I
Yes.
believe.
Yes.
It was an amazing talk. Thank you very much, Ray. Just a beautiful one. I wish you all the best. Well done, guys. Congratulations for your training. Well done. Thank you very much.
Thank you. Thank you very much.
We are just. I think we are done for the day today. Thank you, sir. Thank you very much. I appreciate it. I think we're done for the day today for our social media, and thank you very much. Thank you.